Perfect. So it should have alerted you all that we're doing that one there. Perfect. So just confirming, just with nod of the heads, everyone can see the ECG101 with an ECG at the background. Yeah, perfect. Oh, let's transcript that as well. Let's just turn that off. Okay. So I'll just introduce. There we go. Get Aiden in there. I'll just introduce myself just quickly. So obviously I know a lot of you, and it's so great to see so many familiar faces, but there's quite a few AAPs up in the Brent kind of area that I've never met before, which is fabulous. So excited to have you here. And this is basically what the session is really, really kind of built around. Speaking with a fab friend who is a new AAP, she mentioned the lack of kind of ECG training that you got due to your job role. So that's kind of where this came in and where the thought came in. So my name's Kathleen. I'm a paramedic with the London Ambulance Service. I work operational, but then also 50% of the time I work as a university lecturer at the University of West London, so teaching their master's practice program. So pulling kind of some of the information I've got, I've kind of pulled this this lecture together for you guys. As I said, it will be recorded. Anything afterwards you can pop into the chat. More importantly, just want to make it as interactive as possible. So if you guys have questions, just turn your mic off and just speak. You can put the hand icon up if you want to, or you can type in the chat, but I have no problem if you just talk. If you have the question, someone else probably has the question. Okay, so if you're sitting there and thinking, oh, this is a bit silly, it's probably not silly. It's someone else has probably got the exact same question, so please do speak up. Other than that, if you want to grab a pen and paper and pop that down, that'd be great. Or if you've got your iPad and you can type away on that, that works. It's just because we've got some tasks that are within it that will you'll need to kind of document some things down. So let's kick off. So that's a bit about me. That's how today's gonna kind of go. So what we will be covering today. So today we'll be going through the basics, which sounds really simple, of when to do an ECG. We'll be covering some basic cardiac kind of physiology, because I don't believe that you can fully interpret an ECG until you understand the basics of what's in a P wave, a QRS and a T wave. With that, we'll be defining and understanding how a wave is generated, and then breaking down to the P, the QRS and the T segment and the intervals within those. So what I've devised for this, to keep it simple, there is a full 10 rules or 10 steps with ECGs, but we'll be going through just a 6-step simplified method, because there's a lot of other things that are important, but I think this 6-step that I've pulled, and it's not mine, lots of people have obviously done the same, is probably the most relevant for you at this learning stage. And then at the end, to make sure you guys are all listening, there'll be a little bit of a quick quiz, which is through Slido, and you guys can hopefully get on board, and hopefully it'll show me that I've hit it at the right level, basically. So with that as well, I understand that we've got a few paramedics here, which is absolutely awesome. But if you get halfway through this and you go, I know all this just isn't hitting my learning needs, absolutely fine if you guys want to dip out. I wouldn't be offended or anything like that. But for a lot of you, hopefully it will be beneficial. So first thing to do is, on any other device that you've got, so your iPad, your phone, your desktop, anything like that, just type in www.sli.do, if you don't mind, and it should give you this quite a large screen, and it should give you this one here. There is a Slido app if any of you have used that before, and you can use that too. But just show me with thumbs up or on the message center saying okay if you've got it all. And again, for anyone who last minute joined, the session is recorded, but if you want to turn your camera off, that's absolutely fine. Perfect. So has everyone got access to it as yet, or is it not popped up? Yeah. And it should be active for you now. And does it hopefully should be a poll, and you can just type some words in there. Has everyone seen that? Yeah. Perfect. Got some nodding heads. So just type in there, try and keep it as maybe even just a sentence of when you think you should do an ECG. So if you can keep it simple, great. If not, if you want to put all the reasons in there, go for it. But you can answer a few times on there. And I'm 90% sure this is all anonymous, so you can put anything in there. Please keep it professional. Perfect. So we've got a little words coming through. So chest pain, if the patient has chest pain, lots of chest pain discomfort, shortness of breath. Perfect. So that's all working. I'll give it another minute or two for everyone to go with that. Chest pain of some. BM over 10, I like. All unknown cause, great. Old, I think that's supposed to say don't know why someone's sick. Old, don't know why sick, yeah. T-lock, the T-lock's getting a lot there, which is great. Overdose, fainting episode. Recent tooth infection. I don't know who that one was, but maybe they've had an experience with a recent tooth infection that was bad. I suppose your pericarditis and stuff like that, is that the pathway you're going on? Important cardiac history. Okay. Good. There's a lot of the common one, so this produced, I can't get it onto this other one, but see if that makes the vision better. There we go, you should be able to see me a little bit better now. What we did get is it created, I would have liked to get this on there, but it created like a word jumble of all the different things that people said. And the ones that are big are the ones that most people said. So we had T-lock and chest pain, which is really good. So might sound silly, and I know this statement is going to be brought with maybe some differing opinions, I guess. But with an ECG, it might sound silly to say when do you need to do an ECG, but knowing when to do an ECG is as important as knowing when not to do one. So obviously we've got all our stock standard symptoms, which is what everyone kind of put in there. So chest pain, tightness, shortness of breath, blood glucose. You walk in and you look at them and they look like they're having an MI, which we've all definitely done. And your clinical rationale says I'm concerned. So what I'm trying to say here is, as we're going to go through, if you don't have a clear indication to do an ECG and your clinical rationale doesn't think this is in any way cardiac, don't do one, okay? And it might sound a bit bolsy of me saying this, but this comes from Mark Whitbread when I was speaking with him about ECGs, and he wrote basically all these protocols. And speaking with him, his rationale and why he puts that in there and why we have these guidelines is because if you find something you, in a way, didn't want to find, it wasn't clinically relevant for the out-of-hospital environment, you're going to get yourself in a very sticky situation. The reason being, a lot of people have some weird things in their ECGs, but even if it shows something weird, if it's not matched with one of the pathways that indicates immediate acute emergency care, you're in a very tricky situation because you've got an ECG that's odd, that in 9 times out of 10 is probably normal for them. They've got things like high takeoff for young males and things like that, where benign early repolarization is the fancy name for it. Their ECG always looks like they're basically having a STEMI, but they're not. So what I'm saying with this is, I'm not saying don't do them. And if you've got that bit in your mind that thinks, oh, this could be cardiac, definitely do it. However, what we don't want to see, and I've worked with many people who do it because of their training, is they say, we're leaving them at home, let's do an ECG. And that's what I'm trying to steer away from. Because if you were going to leave them at home anyway, you don't need to be doing an ECG to leave them at home. And this comes from Mark Whitbread when he wrote these guidelines. And if you look at all the guidelines, there's nothing in there that says we have to do an ECG on everyone to leave them at home. The argument, because obviously there will be some people who go, oh, well, I found something one time and they were having a STEMI. The argument there, I guess, would be that maybe your history taking hasn't been as good and there's actually been a symptom in there that you've kind of missed. So straight from the Cardiac Care Circular 12, which is what I'm going to refer to quite a bit through there, is ambulance clinicians are expected to make their own clinical judgment about when to take an ECG. So there's no hard and fast rule, but what I'd like to impress upon you is you're indicated. You've got something that goes with it. So what these are all from here is, and the reason again I said that say you've got your patient who's got ST elevation on there, which AAPs we're going to go into, because I understand you didn't get a lot on it. You've got this ST elevation, but with this criteria, they don't have chest pain, they don't have tightness, they don't have sweaty, clammy armpit. You did it because you wanted to leave them at home. You're in a very tricky situation now. You've got this patient, and what do I do with them, basically? So where it comes from being good at knowing when to take an ECG is about this, knowing this criteria of what matches. And whenever, as I'm going to go through, whenever you get a patient with an odd ECG, you should be opening up the cardiac care circular, carry it with you at all times, and then you've got it there and it tells you the answer. It makes it really paramedic proof or ambulance proof. It simplifies it for you. Same with things like left bundle branch block. You open it and it tells you in here. Left bundle branch block on ECG, these patients must have cardiac chest pain and must look like they're having an MI. So these patients, and there's a whole lecture that I do on left and right bundle branch blocks, which isn't for today, but follow that protocol. If it doesn't match it, that's your rationale for why you didn't glue them to a cath lab or whatnot. Okay, and there's lots of weird things in people's ECGs. So moving on with that, that's just the very basics kind of there. I would say, however, be cautious. I'm not saying you have to do an ECG on someone who's elderly, because they've obviously got abnormalities, but be cautious with your atypical presentations of elderly and diabetics. So painless MIs are unusual, however, they're not rare. So ones that I definitely remember is the elderly patient who just had a niggle in her shoulder. And we know that we've got this shoulder, arm, pain, paresthesia, things like that. And they can trigger these things off because of their pain pathways are not the same as me, for example. Other time to do it, which doesn't fit in with the cardiac care circular, is if they're clearly unwell and you're clueless. You walk in and you look a bit like this. You're like, why are they so unwell? Everything's fine. That's obviously enough of a rationale then to do an ECG. Okay, because I'm not trying to divert you away from doing ECGs. I think they're good, but they need to be put as the whole picture. The next thing I'd say is, this is just, I suppose, from experience, it's not scholarly, but beware of the sweaty, middle-aged, overweight male. If you're there and you're trying to keep those dots on by holding them on, they're very sick to start with, unless they've got diaphoresis normally, but beware of that patient cardiac-wise. The ones I have are AAA dissections, where I've had where patients very well, and he was just sweaty. ECG was fine, everything was fine, but just very, very sweaty. And there's a whole reason why these overweight males with certain demographics and things like that, they may present with a very bad ECG or be having an MI. So beware of that one. If you've got that sweaty patient and you're not sure what's wrong with them, watch them very carefully, basically. The other thing, it's not to be cautious with. Sorry, go ahead, Emma.
Said you've just described me.
Hopefully not. In the context of the situation. So if it's the middle of summer and they're hot and it's normal, that's fine. But, you know, ask the patient, is it normal for them? It's all about what's normal for them and abnormal. And hopefully if you've got any cardiac symptoms, you'll walk yourself up to the hospital. Anyway, so going on, the other thing I just want to mention, if you've got a ventricular tachycardia, so someone is very fast heart rate, I had nowhere else to put this, so I've just popped in there. These ventricular tachycardias are rarely associated with a high mortality rate. It's something like 1 to 2%. There's usually something else going on. So if you walk in and they've got a heart rate of 150 and they're in SVT, it's okay, chill, do what you need to do, follow your protocols. They've got a very low mortality rate. So it's just something I wanted to know, because I've arrived on scene before and people have been very concerned because their heart rate is 180, but they do have a relatively low mortality rate. So let's crack into kind of the juicy stuff. Now this obviously might be really, really basic for some, but new to others. So let's start at the basics. So the basics is this textbook heart rate of 60 to 100. Okay. So hopefully you've all seen there that's what the textbook's saying. That's great. Anything under 60 is technically classed as bradycardia, and anything over 100 is technically classed as tachycardia. And can you guys see my cursor here by chance? No, that's okay. That's fine. Have I got a cursor there? Maybe I've got that one. Laser pointer. What's that do? Can you see that? Some are saying no. That?
No.
No? Okay,
No.
that's weird. Let me just go with that one and that one. What about that?
No.
No, okay, weird. That's okay. I'll make do. So we've got the over 100 is tachycardia. However, what I would like you to see is that heart rate, a normal heart rate, is relative. Okay. So what that means is we've got supreme athletes up here who their normal heart rate sits between about 38 and 41. Okay, that's their resting heart rate, and that's normal for them. So if you go into someone and they've got a bit of tachycardia or bradycardia, consider if it's normal for them. Other things like children will always have a higher heart rate. The younger they are, the higher their heart rate goes. And then other things, other environmental things like alcohol, drugs, diet, caffeine, even sugar. You have a bit of sugar and then your heart rate goes up a little bit. And even reflecting on myself, I looked at my Fitbit because everyone's got one of those now and things like that. And you can see that I'm not a supreme athlete or anything like that, but this says my resting sits around 50. So don't be concerned if your patient's if the patient is intoxicated and asleep and their heart rate is 50, it might just be kind of normal for them because they're so heavily sedated by alcohol or what have you. So it's just to bring that into your awareness that can be normal for a lot of people. So what we're going to go through now is just the basics of what's going on in the heart. So making it really simple, for your heart to contract, you've got two kind of phases. You've got the electrical and then you've got the mechanical. So the electrical is this system up here of the heart in the green highlight, where we have the electricity that is propagated and started in the sinoatrial node. Okay, that's right. And then it flows through the heart. This is the electrical component. The electrical component tells the muscle to contract. And the myocardium being the muscle, it tells it to contract. If you've got no electricity, if there's no electrical depolarization, there is no muscle contraction. Okay. You can have electrical conduction. However, for some reason and many reasons, it's not conveying to the muscle to tell the muscle to contract. Okay. So it is possible, and we're going to go through that a little bit later as to why. But those two phases is what creates. So why I'm talking about this is because we briefly need to understand the electrical physiology to understand what's going on in the ECG. Because the ECG is a tracing of the electricity, not the myocardium. So what we have up here is we have our SA node, which is right up top. Our SA node is the normal dominant pacemaker cell. So the SA node fires on its own, even if you took beheaded someone, you took someone's head off and they had no impact from anywhere else, that SA node would still fire generally at a rate of 60 to 100. It has what we call automaticity or maticity. The SA node, if the contraction is generated through the SA node, this is known as a sinus rhythm because it's the sinoatrial node. Anything outside of this SA node is considered abnormal. And there's a lot of different pathologies that happen with that. So what happens though is the SA node then sends all these different things, sends it through a very predefined pathway. So where all these green little fibers are, it's told specifically to go there and nowhere else. It goes through the atria. It's met at the AV node. And the AV node is the only, in a normal heart that works perfectly, is the only entry to the ventricles. Okay. So it's like it's the gatekeeper to the ventricles. It decides if it's coming in. And 9 times out of 10, it works perfectly and it lets every time an impulse goes through to propagate it to the ventricles. When it doesn't, that's when we have a problem, we get blocks, so on and so forth. But just really simply, it goes through there, goes to the AV node. AV node propagates it down through these red fibers into the ventricles to tell them to contract. Within this electrical pathway, the electrical pathway is connected to the muscle, the myocardium, and it tells it to contract that way. And it spreads out all the way along. This is just a very simple diagram. So that's the electricity component. With that as well, we have something called intrinsic rates, which is important to understand for future things that we're going to discuss. So as I said, the SA node is a rate of 60 to 100. It beats on its own. And actually, I looked at all the literature, and the literature says we don't know why it does that. We don't know how this cell has automaticity. It just does. And we don't know how it creates electricity out of nowhere. It is impacted by, obviously, if people are stressed and anxious and alcohol and all those things, it acts on the SA node, but generally it fires on its own. If the SA node, for any reason, stops and just stops working, the AV node will take over, okay, as a backup. The AV node, however, it's only good at beating or propagating, starting the automaticity at 40 to 60. This is where we start to get into things called about first, second, third degree blocks. If that fails as well, our chain of command says that the ventricles pop in and they will start firing, but only at a rate of 30 to 40 max. So, and there's a ventricular generated rhythm, which would need to be another lecture altogether. But if you're down in that range, start considering whether it is there. That's just a little bit on the intrinsic. Have I lost anyone? Nope, good, perfect. So now we go into the myocardium, to the mechanical phase is the best way I could put it. Pardon me. So we've got the electricity, that sends it to the myocardium. The electrical impulse tells the myocardium to, at a very specific times, to contract. Atria, then ventricles. When there is no electrical movement, because at times there's tiny little pauses in the ECG, when there's no electrical movement, everything is basically almost at a standstill. There's nothing really going on, no electricity going here, none going there, but it's microseconds. That's just important to remember, and we call that coming back to the isoelectric line. So something you may have heard is about PEA, and for some of you AOPs, you may have had a case and gone, oh, I don't know what that means, and I'm too nervous to ask. What it basically means is we've got this electrical component going on, but the myocardium contracting, that second part of that process, is not working for whatever reason. There's a heap of different reasons. So just something on that, which will let me open up now. Share content. Just got a quick video here, but it's not. Let me just try and share my screen. Okay, can you guys see YouTube now? Yep, perfect, great. So it needs to do a disclaimer with these because I forget, some people are a bit wheezy on their tummy. Absolutely fine, you can turn your screen away for a minute, but it will show a heart. So just to be aware, speak up if for any reason you can't see it. The recording the vocals may not be the best on it because it doesn't work as good. So basically what they're doing is they're pulling out this heart, and this is now a lot of how they transport or they're looking to transport organs. And they literally fill it up with blood, give it a little push, and then it starts beating on its own because of that automaticity. It's not quite coordinated yet, but it's getting there. And that's the main purpose of this video, to show you that getting there phase, that it does it perfectly at its time. And as you speed the video up, after a few minutes, it gets into a lot more a coordinated movement. And that's it. There you go. You can see it there. So top, bottom, top, bottom, top, bottom, top, bottom. So those atria are up there, ventricles down the bottom, atria, ventricles, atria, ventricles. Quite hard. It can be a little bit tricky. There's a better one as well. There. So that really coordinated movement. We've got another one there. Boom, 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 boom. We've got the atria, then we've got the ventricles, and they need to do that for a very specific reason. We'll just go back to that. So again, atria, ventricles, atria, ventricles, atria, ventricles. So, where are we? There we go. Are we all back in the room? You can see myself? Perfect. So that's just to give you that that view of what you can see with that heart and why it's important that it is perfectly coordinated. Oh, where has this one gone? Hang on one second. Must be somewhere. Hang on 2 seconds. Ah, it's gone from there. That's okay. Apologies, just give me one moment and we'll get this back up. It seems to have just gone there. That's okay. So, just while that's loading, I'll upload a copy. Sorry, they'll just take a minute to upload there. So it's kind of going through the reasons why we kind of need that coordinated movement. Let's bring this one up here. Apologies, that should have stayed in, but for some reason it didn't. That's okay. There we go. So moving on with that, we've got the myocardium, and you guys can watch that full video there. What we're going to go into next is kind of what actually is an ECG. So obviously we know that we've got that, that electricity there. So the ECG really simply is a graph, okay? So the ECG is a graph that records the magnitude and direction of electrical impulses, okay? So it's not talking about the myocardium, and it can never tell you what the myocardium is doing, but it gives us a pretty good indication if we've got a pulse and the electricity shows that. So we will resume from slide 11, and you can all see the slides again, hopefully. Yep, perfect, great. Okay, so we'll just wait for that to load for a second. There we go. So what actually is an ECG? As I said, it's looking at the magnitude. When we talk about magnitude, we're talking about the amount of amps. So how big that voltage is and the direction of the electrical impulse. So as I said, it only looks at the electrical component, and the ECG should be used as a whole clinical impression and never in isolation. You should never just be doing an ECG outside of getting that history. A great paper I was reading the other day that 80% of our clinical diagnosis as paramedics are made from the history alone. So it's great. I know all this stuff about ECGs, but I never do an ECG. It's one of the later down things I do until I've really got a good, succinct history. And as you know, it can make a dramatic difference in the out-of-hospital environment about what we can do for patients. So really quickly, this might take people a few times to get their head around, but we do need to talk just briefly about ECG paper. So can you see my red cursor now by chance? Still no? Weird. Okay, no problem. So with the ECG paper, we have the vertical axis, which is up here with the arrow, the blue arrow going vertically. Each little box of this ECG paper means something, okay? So it's not just there because it looks like a good pattern or it looks medical, it's actually there signifying something. So on the vertical axis, we have the amplitude. So the amplitude with this is very simple, and this is what we talk about when we talk about a mil of elevation. You might hear someone say, oh, they had 10 mil of elevation or they had 2 mil of elevation. They would have had 2 of these little boxes. So the ECG paper is made up of the little boxes and these big, kind of more pronounced boxes. Within each large box, they're basically 5 by 5. Okay. So what we have is 5 along the horizontal axis and 5 along the vertical axis. With these, with the vertical axis, that is our amplitude, that is our how much energy is being pushed out. And with our horizontal axis, that is our time. As time goes on, we can see how much time has gone on with that. So one small box, so one of these tiny, tiny boxes here, represents 0.04 of a second. Okay. So it's just talking about time. And obviously, if we times 0.04 by 5, because there's 5 small boxes in there, we get a total of 2, or 0.2. 2, 4, 6, 8, 10, 12, 20, 16, 18, 20. Okay. So that means that each of these large boxes is 0.2 of a second. Okay. So it's going to take a few times to get your head around the time axis of it. But it becomes relevant when we're talking about blocks and measuring QRSs and things like that we will need to do on occasion. So the time axis is obviously you've kind of just got to write down 0.04 and 0.2 a few times to get it into your head and measure it a few times on a real ECG to understand what you're talking about. The amplitude, which is the vertical axis, is pretty easy. One box, one small box, 1 mil of elevation. Okay, but that becomes really important when we talk about ST elevation and things like that. So the other thing that you may see written in some pages is you may see 40 milliseconds and 200 milliseconds. When you're a new learner, just ignore it. Just don't think about it for now, because it's just another way of interpreting it, but it can confuse you. So that's the paper just really briefly. Did anyone have any questions on the paper? Did it not make sense to anyone? No? Cool. So now to understand how a lead, how you get that P, the QRS and the T is on your paper, I'm going to explain it in 4 different ways. The same thing, but just pitching it in a slightly different way that might make sense to some of you, it might make sense to other people. If you can get this principle down pat of how lead 2 is generated, which is all we're focusing on today, when you're going to look at other leads, the same principles basically apply. Okay, because it doesn't change, it just changes where you're looking at. So if we look at the picture of the gentleman with the arrows on him, when you put a lead on someone, so you put that dot on someone, just for imagination's sake, where that dot is, envision that as a camera, okay? And what that camera's doing at that bottom end, so when that lead, so if we talk about this lead down here, we're just talking about lead 2. Okay, so this camera that is normally at the person's left hip, that's lead 2. So that's the easiest starting lead that we always put people on because it's easy and it gives us a full overview of the heart. So where that camera is situated, like a speed camera, is sitting at his hip and it's looking at, for argument's sake, the electricity running from his shoulder all the way through his heart, and then it's looking at it from his hip. If we look at the top right-hand kind of cartoon there, you can see lead 2, and then you can see it connects with AVR. So that's kind of the path, just for argument's sake, that it goes through. So the electricity is mapped and kind of logged in the atrias, along the ventricles, and then that's about it. So it sees a big, nice overview. When the electricity is coming towards the heart, or when the electricity is coming towards that camera, that dot down the bottom, on the paper, it will create a positive inflection. Okay, so what that means is it's isoelectric, so it goes across that nice flat normal line, and then as soon as there's some electricity, there's a bolt, it creates a positive flexion. If it's a little section of the heart, just for argument's sake, like the atria, it gives a little deflection, which is the P wave. If it's a big whack of electricity, it creates something like in the ventricles, it's a bigger amplitude and a bigger flexion. If the electricity then, instead of coming towards the camera, decides to go away for whatever reason, say there's a blockage in there, and like a train or a car, it has to drive around the blockage. If it's going away from it for any reason, it creates a negative deflection on the ECG paper. Okay, so this concept, once you've got that in your head, the rest will all make sense. So depolarization is just a fancy word for electricity. The electricity is coming towards the camera, it gives a positive, it goes up. If it's a negative, it's going away from this camera at this guy's hip, it gives a negative deflection. So what I mean by that is like this. So if the electricity is going away, it gives this QRS complex, just keeping it at the QRS, this picture. If it's not going completely away, but kind of to the left, kind of to the right, it might go in the middle, but it'll still be predominantly negative because it's predominantly going away. If it's smack in the middle, like in the middle of this picture here, there is still electricity, but it's kind of in the middle. So it creates a what we call biphasic. So it goes up, goes down. And right on the end there, if it's coming all the way straight at that camera looking at it, it's a full positive inflection. Okay, so when we're talking about the up and down, which is the voltage, the 1 mil, 2 mil, things like that, that's what we're talking about. What was I going to say? That's the voltage that goes through there. So what we have here again is an electrode here, electrode here. If it's going away from this, the paper will represent like that. It'll be a negative deflection. If it's going towards they call them vectors, but they're basically just cameras. If it's going towards it, it'll create a positive deflection. There is an Akadoodle video there. Akadoodle is great for ECG resources, but I'll play that at the end if we have time. So that's kind of the best way. As the P wave is created, it's a little bump because it's a little bit of myocardium, big ventricles, big bumps, so on and so forth. So it's just another way, the fourth way to kind of look at it. And what it is this triangle that you're going to hear lots about. But again, it's just bringing that, if you see that line that runs from RA, from the right arm, all the way down to LL, and the line in between it is that lead 2. So it's just a different way. If you can get your head around this, and you can get your head around that electricity, and this coloured line with the blue, the green, and the red is a really good description of it. Take that red line and put it straight across the heart. That's what it kind of looks like. Okay, that's what it's looking at. It's looking straight at a really long best view of the heart. You can get your head around this. Each lead just builds upon that exact same principle, but the camera, instead of being at the hip, is right on the chest, and it's looking at a slice of the heart. So before we go any further, that's quite content heavy to get your head around. Is it anything not making sense to anyone? Is there anything that needs rehashing or anything that I've confused you with? And if there's not, shake your head and say no, or just say no. No? Good? Okay. If it doesn't, you want to come back, it's absolutely fine. We can do it one-on-one. So that's kind of the content stuff there. Getting your head around that is something that they don't often teach a lot of the AAPs, unfortunately. They just throw at you that the P wave is the atria, and they don't actually explain why that electricity comes up that way. So moving on, to recognise abnormal, all the weird and wonderful Bragadas and Wolf-Parkinson White and all these things that people who you feel are much more intelligent than you say, and you don't know what they're talking about. To understand all of that, you first need to understand what's normal. So to recognise abnormal, you need to first understand normal. And that's what today's really going to be about, is getting that really normal down pat. And then towards the end, we're going to cover a few little things that are abnormal. So the normal ECG waves, okay, so these are the waves of the ECG that you see. In the P wave, as we said, the P wave is all about the atrial depolarization, okay? So that depolarization, just a fancy word for the electricity going through there, okay? It's sending the electricity through, and that causes the myocardium to contract. The PR segment, which we're going to go into, is where the AV node, like I said, it's the bouncer, it's the gatekeeper to the ventricles, where it holds the charge momentarily. The reason it holds that charge is to allow for those atria to contract the blood into the ventricles. Okay, so there's a purpose. Every single dot on this, there is a purpose. It's purposely built. The QRS that you're going to see that we're going to go into is about the ventricular depolarization. Okay, so the ventricles have that shot of electricity. The electricity flows all the way through it, and then causes the myocardium to contract. And then finally, what we're going to talk about is the T wave. So the T wave is slightly similar to the P wave, but a bit different. And that's where repolarization occurs. And that term is basically like where it regenerates and gets ready for the next contraction. So it basically relaxes and kind of recharges in a very, very short second. What's important to understand, when there is no electricity going anywhere, it's not going left, not going right, get it into your head that for that moment in time, there's technically an asystolic there, okay? So no electricity, net movement is going anywhere, and that's important, okay? But they need that. You need it's like your R&R for your heart. So moving on, there's just another way to kind of look at it. And what we would have seen in the video is we've got, if we start on the left-hand side there, we've got the atrial contraction. So the SA node sends the electricity. Once it's complete and it's through the whole of the atria, both sides, it gives that P wave. The AV node holds the electricity, and that's where we see that little isoelectric flat line before we get to the QRS. The electricity comes momentarily sideways for a little bit, and that's how we get our first deflection down in this little the third section along, and then it goes all the way and whoosh all the way through the ventricles, and because it's a big thick muscle, it's a big thick voltage. When we get that all the way through, it happens very, very quickly, as you saw in the video. We get this ventricular depolarization. Then the one that's sometimes hard for new learners to get their head around is that T wave, which is the repolarization. Because you think, oh, the electricity is going in there. Why does it give that? Why does that give that wave? It is a bit complex why it is, but just to understand that that's what occurs now is the best way. So again, another way for other people to learn, it's got this red coloration, and it shows a slightly different way. And this made more sense to me. So you've got your P wave, again, which is the SA node sending it out all through the atria. Short pause, which is this second video, which is the depolarization is complete in the atria, but the AV node is holding the charge. There's no other charge going anywhere else. It's holding it, waiting for the atrias to empty all their blood into the ventricles. And then once it's done that, because it's very good, it releases the electricity into the ventricles, and that creates your QRS. Again, there needs to be another pause, which is once the ventricles have completely depolarized, they need to have a pause to let the blood out, to eject it into the rest of the body. And then we've got our repolarization, which is our T. So we do have some as I said before, isoelectric line will be referred to throughout, but we do have some parameters that these sit within. So don't get overwhelmed by needing to remember all of these. Once I'll hopefully impart on you the one or two that you really need to remember, and you can go from there. But these are the set parameters that each of those should fall between. So what this is saying is the PR interval needs to fall between 0.12 and 0.20. And as you remember from earlier on, 0.20 is 5 little boxes. So one of those large boxes is where it needs to fall between. This, don't get overwhelmed by this. We'll come back and we're going to break it down in order. So does anyone need a quick loo break before we get into the real kind of meaty stuff of the P, the QRS and the T? Just take 2 minutes and then grab a snack, grab a loo break, and then we'll be back in 2 minutes. If anyone has any questions, just holler. I can't hear anyone if you, I think a few people have got their mics, their mics mic'd, muted.
Quick question, Kat.
Yeah, of course.
Just a suggestion for future. Turn that off. Oh, sorry, just a suggestion for another class maybe. Would it be possible, just to make it easier, get like a P-QRS-T wave and a picture of a heart, and as the heart is moving, show on the diagram going across like what parts are actually being activated.
Yep, so that's this one back here. So you can see that you've got that P wave there. I was going to
say have it more as like a moving diagram as it's going. What happens to an actual heart? This contracts, that contracts.
Yeah, the other video that I had that I was going to load up has a bit more on that, but it's just a bit hard switching between at the moment. But yeah, definitely understand where you're coming from. It's just that other video, by the time I go back out of that one and come back in. But we'll try and go through it at the end. It might then help consolidate.
Cool.
You're doing
Thank
really
you.
well with that.
Thanks, Jay.
I really enjoyed your snaps picture.
What's that?
That I really enjoyed your snaps picture.
I thought that was in there just for you.
Yeah, cheers. Yeah.
I can't see your face, it's your chin.
That's me on midnight on a night shift.
You just need a quick toilet break because the next bit is quite lengthy. So yeah. Still not working with the cursor. That's okay. There's supposed to be a cursor in here, but hey ho. Cool. So another few seconds, and then we'll come back into it. And I'm getting sunburn in the sun here, which is great. Cool. All right, let's kick back in if everyone's good to go. So if everyone's good to go, what we'll go into now is the ECG and apply those principles of, we're actually going to look at a real ECG now, apply those principles of the P, the QRS and the T, knowing what is going on in the heart with each, and that the electricity coming towards the camera creates a positive inflection and going away creates a negative. We're going to look at that applied to the ECG and break it down. So what I'd like you to do now, I know a lot of you may know all about 12 leads and things like that, but for the purpose of today, if you're a new learner, just focus on lead 2, which is this one on the ECG. The reason that we say that is because it can be very confusing looking at all these different leads, but I guarantee you, once you get your head around lead 2 and you understand ST elevation in lead 2 and you understand a flattened T wave in that, the exact same thing applies to all the other ones. It's just looking at it in a different part of the heart. But lead 2 is our good kind of basic one because it gives a good overview. So just for now, everything I'm going to refer to will be about just lead 2. So just really quickly, some terms that are going to be used for those who, I understand there's a lot of AAPs who are completely new to the service. You may have just been in a month or two, and so a lot of these are going to be very foreign to you. So isoelectric, as I said, is the baseline that the ECG, when there's no electrical activity, will return to. It instinctively goes to its base. That's its home. That's where it's happy. The isoelectric line is the straight line where there's no positive or negative inflection created. When I say came back to the isoelectric, that's what we're talking about. The term monophasic just means it has one phase, so it goes up once. It's one lump. It's like a normal generic P wave is monophasic. When I talk about something being biphasic, it means you have two waves. So you have like a positive bump and then maybe a negative bump. And when I'm talking about positive and negative, we're always talking about it in relation to the isoelectric line. So on an ECG, there is that imaginary line that is where, should you take all the dots off, where that would come back to. So when we're talking about coming back to it's biphasic, it means it goes above and then it goes below that imaginary line that is always in the middle of the ECG, its home line, okay? Concordance is another term that I'm going to use, which means both parts point the same way. So if the P wave and the QRS wave are concordant, it means they're both pointing up, they're both positive. If the P wave's pointing up and the QRS is all the way down, that's called discordance. So they're going away from each other. So that's kind of just some lingo there. And then we've got segment versus interval. We're going to talk about, this isn't as important to know, but just so you understand why there's a slight difference between. With segments, we're talking about the morphology of it. And with intervals, we're talking about the duration. Okay, so how long something is, whereas the segment is slightly different. It's more about that morphology of it. So usually the PR segment is about the P wave, whereas the PR interval is about that flat bit and more about the time. It's just something to give you a bit of insight. So what I've came up with here, there's lots of different step methods, and this isn't completely mine. This is pulled from other people's literature. I've tried to simplify it in something that you can take away from today, you can write down, and you'll have sitting next to you when you look at an ECG. So you have this printed off, you'll have it on a poster, you have a photo on your phone, whatever it is. If you're starting out really simply, this is a really quick 6-step method that we're just going to apply to lead 2, but you can apply it to all the leads. And this is in essence what I do when I'm looking at an ECG. We're going to go through ECGs later to try and apply it. The 6-step method that I think is kind of important is we've got this heart rate, regularity and ratio, and this is a very quick one to look at. Then the second, 1, 2, 3, 4, 5, 6, just make sure there was 6, I put it there. Then the P wave, we're going to look at that briefly. Then we look at the PR interval, QRS complex, the ST elevation, and then the T wave. So basically we look at one wave and we look at each section of it to see if there's an abnormality. All the 6-step method is doing is telling you it's either normal or it's abnormal. It's not going to tell you all the different rhythms it's in or anything like that, but it's gonna highlight things to you. And if that's all that's out, if say the P wave is missing, you'll be like, oh, it's a fine rhythm, but the P wave is not there. So that's what we will be going through. So what I would encourage you to do now is take a photo on your phone or open your iPad or however it is, and take a picture of what's on your screen now of this square, because as we go through, we're going to do ECGs together and apply that, and then we're going to jump on Slido and you're going to pop up what the abnormality was that you detected. So take a photo of that on your phone or a screenshot on your laptop or however it is. If this is really common to you and you know it like the back of your hand, no problem. But just take, because what I've done there is I've put all these things and then I've put them into what you're looking at for each one, which is what we're going to go through. Everyone good? Got a photo? Yeah. Cool. So we're going to break down the bits of this, and I'm going to try and tell you what's in each one and what's important. Okay, as a ambulance person, what's important to you as a ambulance person? So the heart rate, there is a method that you can use to work out the heart rate, and it's called the RR interval. So basically you look at the R's, you count how many big boxes are in between, so those big prominent boxes, and then you divide it, you do 300 divided by whatever it is, okay? So this is very simple, and it's just to give you a way, because sometimes the machine won't give you the rate, okay? Or the rate could be inconsistent. So basically, if we look at this one, we look at this one here, you go 1, 2, 3, 4. There's 4 large boxes. 300 divided by 4, it gives you a rate of 75. Okay, it's that simple. If it's halfway in between box, obviously, you know, a whole divided by 5 is 0.2, so 2, 4, 6, 8, 10. So I would go, say, 3 boxes and 3.8 or something like that, or say it was 3.5 if it was halfway through. It's just an estimate. It's a way to give you a guide, basically. That's all we kind of want to do with heart rate. It's pretty simple. Or you can do it the ambulance way and just look at the number on the top. Okay, there's a number at the top there and it says what your heart rate is. But there is occasions where you need to be able to count the heart rate when it gets a bit further on. The other thing in that box that we're going to talk about is it regular and the ratio. There's no complex things in this one. It's just looking at it. Does it look regular? Do you look across? Are these equally spaced? You can count all the boxes if you want, or you can just look at them. If they look equally spaced, it's probably regular. If they go, you know, nice, and then there's a big pause and then the next one, it's irregular. Okay, and there's lots of irregularities. What we're looking at here with the ratio as well is we're making sure there is a P before every QRS. The P-QRS, P-QRS, P-QRS. Simple, yeah? Perfect. You can talk about AF and VF and PACs and all those kind of things, but it's not probably appropriate for the time we have. So that's where we are with that one. Then we move on to the P wave. There's lots of different things in the P wave that you can tell, but all I want you to know at the moment is it upright, rounded, and before every QRS? Okay, so like I put in that thing to take a photo of, it's upright, so monophasic, it goes one way, rounded, and before every QRS. There is times where it'll be flattened, but generally it's in quite a few leads, you'll see it upright. There is a couple where it's not, and that's okay, but we'll get into that another time. If it looks like this, especially in lead 2, because we're just focusing on that at the moment, it's said to be a sinus rhythm. If the P is creating the QRS, if you cast your mind back to what the P actually is, which is that atrial depolarization, if that's sending the memo to the ventricles to create the QRS, it's said to be a sinus rhythm. What you can have, though, is you can have sinus brady, which just means it's slow. It's got a P, it's got a QRS, it's just slow. Sinus tachy, P wave QRS, it's just fast. And you can have sinus arrhythmias. So they're all working together nicely, and then all of a sudden there's a pause and then it kicks up again. The word sinus is in there if you hear that. So here we just have the top one is just a normal sinus rhythm. The second one is a first degree block, which just means there's a bit of space in between the P to the QRS. And then the third one is a really, really long block where the P, just for your information, sometimes hides under the T wave. So if you're looking and you think, oh, there's no P waves, there actually is. There's just a long block, and there's a lot of reasons why that would occur. But there's a big block in between there. So what I do is I print a long rhythm strip and I just mark out all the P's and the QRSs so I can see it all clearly. So what if the P wave is weird? Okay, there's lots of reasons why it's weird, but just to give you some simplicity, you can read this in your own time if you want to really get your head around it, but it might give a pointed shape or it might give an M shape. And like we said before, with the basic principles, if the electricity is not going from A to B nicely, it's because it's obstructed by something. And in this case, it's usually because the atria is enlarged. So you've got atrial hypertrophy. Does it mean anything? Not really at this stage of learning. It's a nice to know kind of thing. And when we do other things like left ventricular hypertrophies and things like that, it'll become more relevant. But at the moment, it's just to realise that that's there and realise that this lumpy looking P wave is still a P wave, or this biphasic P wave that goes up and goes down is still a P wave. So P wave in real ECGs, as we can see here, there's something called P mitrale, which is that M shape, and then we've got our pointed P waves. So it's just to give you a view of it. So the P wave, in summary, just seeing it's there. The idea of that one was to just make sure you saw that it was there. The next one that is important to count or to look at is that PR interval. So you can see here from this vision here, you can see the PR interval is that top one. So where the first movement away from the isoelectric line to create the start of that P wave, that's where we start counting it. It goes all the way until any deflection up or down from the isoelectric. And that becomes the Q wave or the ER wave. So anything that goes up or down, that's where the PR segment ends. So this should stick within that parameters there. Again, we know that the AV node holds the charge, and there's a reason for this. You can calculate this, as I said, with the small boxes. So this is taken straight from that slide of 0.04 for every small box. Basically, if it's over one large box, the start of the P to the QRS, it's long, okay? And there's a huge range of reasons for that. You can calculate it, or you can do it ambulance style and just look at the number at the top, okay? So the number at the top of the ECG will say the PR interval, and I'll open that up for you and we'll see that in a minute. But that's kind of, that becomes really important, the PR interval. It's probably not as important now, but when we go into first, second and third degree blocks, all they cover is the PR interval. So at the moment, it's a nice to know that it's there, but it's not the crux of this. So again, just looking at the PR interval, we can see the top one, we've got a nice P to QRS relationship because they are in a relationship together. The second one down, which is the slightly grey one, we've got it's a bit longer. Third one, as we said, it was down there. And then the very last one down on the that looks horrible, that wide QRS, you can see there's more P's than QRS's. And that's the main thing to start looking out for. When there's more P's than QRS's, that gatekeeper, that bouncer that holds the charge momentarily, something's going wrong there. And these ECGs down the bottom are our concerning ECGs. These other ones at the top, it's a bit long, no biggie. But when you start getting a bad ratio with that long rhythm strip you've printed, that's when you need to start looking at what's actually going on with the ECG. So, and P waves can hide underneath there. So that's kind of the PR interval. We now move on to the QRS. So this picture is a really good one to really tell you where the P wave actually is, the PR segment there, and what is the QRS made up of. The Q is this orange bit, the first deflection down creates a Q wave. Why they're called P-QRS-T, I have no idea. Someone's just named them that, basically. There might be a reason why, I don't know it. But the deflection down is the Q wave. If that lead was to go up first, the term they give it is then just the R wave. Even though we still call it the QRS is there, the term, the actual term that we give it is the R wave. Just going to get out this one. So that's that one there. You've got the Q that is that first little deflection down. The reason that it does that as well is because momentarily the electricity doesn't go all the way through the ventricles. It goes sideways ever so slightly for like a microsecond. It lets it out ever so slightly to that way, and then it goes all the way along. So big myocardium, big voltage. And then the S wave is this tiny bit, because we're talking about that imaginary isoelectric line that goes through the ECG. If you can see it, this black line, if you keep that line going across, as soon as it dips below that isoelectric line, we technically give that the term of an S wave. There's a short segment, and then there's a T wave that we're going to go into. Butt in if there's anything that's not making sense at all. But that's how the QRS is made up of. And really simply, that's just the ventricles. That's all I want you to take away from today as new learners, that that's the ventricles. So as we said, the QRS deflection is the first deflection. If it's negative, is coined. It's the term that they give it. It is a Q wave. If it goes up first from that isoelectric, it's termed an R wave. But it's okay to say the QRS was this. It's not, no people are usually that pedantic. And we can see a bit lower down on this longer spread here, all the different, what we call morphologies of it. Okay, and as we go towards the end here, we get something called RSR, which a lot of you may know is right bundle branch block. There's a reason that it gives that morphology, and there's a reason we call it RSR and bunny ears and all these things. All I want you to see about the QRS is, one, know where it is, and two, does it have any lumps or bumps, and is it really, really wide and grossly abnormal? Okay, that's the main thing I want you to see with QRS. You look at it, it's neat, it's narrow. The technical calculation for it is it should be less than 0.12. Okay, so going back to that ECG paper that I talked about earlier, that's 3 small boxes. It's 2, 4, 6, 8, 10, 12. So it's a really tight parameter. It needs to fit within that. If it doesn't, it's fine. If it's a little bit wider, if it's 4 boxes, not the end of the world. But what we're looking for is you look at it and it's grossly abnormal. It's wide. Again, I'm going to say it again and again, but again, coming back to if it's wide, if it's got a lump or a bump or it's wider than what it should be, that tells us that the electricity is being disrupted on its normal path. Could be that there's a block in there. Could be that the tissue is hypertrophied, so it means it's really thick now because it's been working hard for years. There can be lots of different reasons, but as a new learner, you just need to understand that that's what's going on there. So the QRS, as I said, you can calculate or calculate an ambulance style and look at the top. So sensing a lot of trends here. So at the top, it'll tell you, and I'll go through that at the end, what the QRS duration is. And you'll be able to look at this literally from tomorrow. You'll be able to have these 6 rules beside you and look at all these and apply it, hopefully. So that's kind of the P and the QRS. For new learners, like a lot of AAPs, that's nice to know. It's good to know, okay, I've seen the P, I've seen I remember she told me there's a little space in there, and then the QRS. These things will become clear as you go on, but what the juicy stuff is, what you're probably going to hear most people go on about and things like that, is the ST segment. Okay, and this is something when I spoke with one of the lovely AAPs I know, she said you didn't get any training on the ST segment and what that actually meant. So while I'm here as well, the things that I'm going to go through today and have gone through today are not to take away from what you're allowed to do and what you've been trained to do. The information I'm giving, I don't know if I said it earlier or not, but is not to give you a skill grade that you're not. It's not to give you a skill grade that you're not. Or you're not to. Oh, I think it's echoing. Are you in it twice? There you go. Thanks. So it's not to override what you have been trained to do. So I know AAPs, you're told not to interpret ECGs and things like that, and you'll always be with someone who will able to interpret them. So I'm not taking away from that and telling you should do something that you're not trained to do, but hopefully learning about the ST segment and all these different waves will empower you to know more about ECGs and empower you to have the knowledge to then go and find out some other things. Because I get that it's a huge concept, okay? And the same for all paramedics and things like that. So now we're moving on to the juicy stuff, basically, the stuff that will hopefully be able to see and it will make more sense. So you may hear as a baby paramedic or a baby ambulance person that the ST elevation, that's what we go on about. So identifying the P and the Q, as we said, and identifying the ST segment is where we get to activate a lot of different pathways and can implement some things. Also looking at the T wave. And the reason this photo of this guy's here is basically because you walk in and you look at the ECG, and like one from Jade that we're going to go through, you can see straight away that the patient is very unwell. So the ST segment. What the ST segment is, again, you're comparing the PR interval, so that little section, the little flat isoelectric section between the P wave and then where it joins again, where this is all pointing about the J point. Don't ask me why they call it J point, there must be a reason, but the J point is what they term that as. When you're looking at it, we're looking at comparing that section of the twin QRS to where it rejoins and becomes back to its baseline. Remember I talked about the baseline and how it wants to go home. It always wants to go back to that baseline. In a normal person, it goes straight back to that baseline. And as you can see in picture A, it matches perfectly or almost perfectly. If it's very hard to tell if there's any difference, it's probably perfectly. As we can see here on picture B, that J point, so it goes up, it goes down, it's the Q, the R, the S, or QRR. We can then see that J point where it flattens out. That section, we compare these two, and if there's X amount of boxes, creates X amount of mils of elevation. So this is where the term elevation comes in. So what you need to do with this is look at lots of them. We're hopefully going to go through a few. I understand we are running out of time, so this may go over just a little bit, or 10, 20 minutes. So if anyone has to leave, no problem, but it needs to be covered, these bits. So ST elevation or depression, if it's above or below that line, it is significant. It means something. It may not mean that you have to take them to hospital. It may not mean that they're having a cardiac event, but it means something. Okay, so you need to know a little bit more about that. So one small box, if you measure the J point, as we've said, compared to that PR segment, like I told you, like we went through before, that little flat spot, you compare those and you compare how many boxes are in between, it'll show you what mil of elevation or depression we have. So marking that one up here, hopefully you guys can see this in here. You're comparing the line, the bottom line is the PR segment. The next line is that J point. And that blue section that I've coloured in between, that is how many boxes are in between. Okay, and we can see it on here because it looks like at the first bit there is a notch. When it comes back down just above that blue section, there's a little notch there. That's not the J point. The J point is where it purely flattens out. Sometimes it is hard to see. I definitely acknowledge that. So the QRS, again, we're looking that it's lumpy, bumpy, abnormal. And then we go on to see this ST segment. Okay. With the T waves and the ST segment, what you can get is whatever the QRS does, the T is like the annoying little sister. It'll copy it. So if you have an abnormality of the QRS, like, you know, there's a block in there, there's something that's making it be really wonky, you can expect to see that abnormality with the T wave. So things like when we speed a rate up, when we have tachycardia at 120, because it's so quick, the T wave does some funny things as well. So it's just something to come into your awareness that it's not always as bad as it looks. So with that ST segment in a normal, just looking at lead 2 for the moment, we're looking at that. We've got that elevation there. Say it met all the other criteria, the patient had chest pain, this and that. That's a confirmed STEMI, basically. Say it met the criteria, which we're going to go into. That's what they talk about when they say a confirmed STEMI, is there's ST elevation, myocardial infarction. It's an acronym. So once you've got that, nothing else kind of really matters. There's other things that are going to go through, which is right leads and posteriors and things like that. But that's the main thing. Take the big things that you see in the ECG. So going on from there, there's a lot of things that can skew effort, but we'll go through that. Again, there's another paramedic proof or an ambulance proof way to find out what the ST is. And the ECG very nicely gives you this level on the side. So hopefully you can see all this ECG here. And if we look across this ECG, because there is a bit of artifact, which is this artifact in here, can be quite hard to see. So if you look over at the ST and it's given you a J level, you can see minuses and you can see something without a minus. So if it's got a minus, it's depression. If it's not got a minus, it's elevation. And we can see here that the system calculates it, and it usually is quite good at this. Calculates there's 1.2 mil of elevation in V5, 1.5 mil of elevation in V6, and the main important one is in 2 and 3, there's 1 mil in both. And if I look at 2 and 3, they do look a little bit concerning there, but it is hard to see through the artifact. Try and go there. So there is depression in these leads as well, and I need to do a full session on just the 12 lead and STEMIs. That will be a full session on its own. But for the moment, it's just giving you the tools to ambulance proof it and find the raw stuff that you need to help make you help with that decision, help understand it. One thing I would say is ignore what it says at the top. So this top section that a lot of people look at, a lot of the time it can be wrong. The only time I would take a little bit more caution with it is if it says that meets ST elevation criteria. If it says that, doesn't mean it is that. But start re-looking at the ECG because the system is quite good at telling you when it thinks there's something wrong. It's got a lot of calculations in there for 20 grand. So with this ECG as well, I wish my cursor worked, but it doesn't. Up the top, you can see 12 lead 6. You can see the heart rate is 65. Again, you've looked at the top, it tells you. The next thing you can see, hopefully all, is PR, and it says 0.164. So that's less than or between our less than 0.20. So tick, that's great. Then I go over to the QRS, and I can see it's a little bit wide, but 0.12. And then we've got some other things down here about QTC corrected, but that's for another day. But you've got all these measurements up there. We've got our age, we've got that they're male, and we've got the STJ section on the side. So in a really basic way, STEMIs need to be a whole lecture on their own, but really basically, when is it bad? Whenever I got this ST elevation and it's bad as an AAP, and I'm with another EEC and they're looking at me and I don't know what to do, what I would say is if you've got ST elevation, you've now been able to see it, is pull out your cardiac care guidelines and your circular. It will tell you what to do, okay? It will say that they need to meet this criteria. So pull it out, look at it. Patients with chest pain or tightness, suggestive of acute coronary syndrome, that's lasted more than 20 minutes, rah-de-rah-de-rah, and the second component of that, they've got a 12-lead ECG showing clear ST segment elevation in 2 or more adjacent leads. We're going to talk about adjacent leads. In summary, it's talking about the adjacent leads in anterior and then all other leads. So for males, very, very simply, more than 2 millimeters, so that's the 2 small boxes in elevation. So it's no longer the time, it's the vertical axis. So you've compared the PR segment to that ST, that J point, and it's more than 2 mil or 2 mil or above. There should be a little line under that. And for females, it's less, it's 1.5. In all other leads, it's 1 mil, so just one little box. So it's quite a small amount. With these, we're going to talk about contiguous leads because that's kind of somewhat important. What we're talking about here is the 1.5 to 2 mil of ST elevation needs to be in V1 to V4. So I've put a box around V5 and V6 because they go in the other, they go over to the other side. So when I'm looking at ECG, I divide it in half. I look at maybe my anterior leads first, which is this V1, V2, V3, V4, 5, 6. I look at those in isolation. I do the 6 rules applied, see if there's anything abnormal. Then I look at these in groupings, which we're going to go through, which is our V5, V6, 1 AVL, so on and so forth. But very simply, with those basic principles applied, you can look and see what we've got there. And very simply, we look across this. We've got a few other things. Oh, I've got some depression there and some biphasic waves of V5 and V6 you can see there. Big thing that jumps out to me, and hopefully you guys, is in lead 3, I can see some elevation there. And that's it. That's your big thing. That's your big thing that you need to focus on as the main culprit and the main problem. But that's what it means when we talk about adjacent leads, is the ones that are next to each other. The better way to explain that is this picture. What is adjacent? So the ones that are in coloured are the ones that are in a way next to each other, or they're together in a group. So when they talk about 2, there needs to be 2 or more contiguous leads. They're talking about for your anterior septal, this green part, it needs to be V1, V2, or V2, V3, V4. If you've got elevation in V4 and V5, it's still something, but it may just not meet the criteria. Okay, but not to say it's nothing, because that's obviously there and it may be developing. But what it's basically saying is AVF, this red section, and V3 are not contiguous. So if you have elevation in just these two and nowhere else, technically doesn't meet the criteria, but keep looking because maybe there's something else in a lead that's nearby. So these are adjacent leads. This AVR, for the moment, it's the forgotten lead. It does have a purpose, but when you're a new learner, just put it out the window. So that's how we group them, and you do just kind of need to go through these. The only way I learned them is that actually I'll leave that to another time. It's just a bit too complex. So that's ST elevation. Is there any questions on ST elevation? Because I know it's a topic that gets covered with a lot of people. Have I lost anyone? Or everyone completely clear? Yep, I see some head nods. Perfect. Okay. So we're getting towards the content is almost drying up now. Once we get to that T wave, we're done with that. We're going to apply some of this to ECGs. So ST depression. So again, that same principle. You mark it out from the PR segment to the ST segment, and you see that it is below that imaginary isoelectric line, and it's a mil or 2 mil. It means something. What you need to do is open your cardiac care circular, look at high risk ACS, and see if it meets the criteria. High risk ACS and left bundle branch block, however, spending some time up in the cath lab, are the most common inappropriate activations. So left bundle branch block, paced rhythms, and these high risk ACS ones, generally they they usually look quite unwell. There's always occasions where they're not. You might get someone with a bit of subtlety and they just had a developing one. But there, as you're going to see, ST depression can be relevant or prevalent for so many different reasons that aren't an acute MI. So it's important to really open this up because it will tell you ST depression of more than 1 mil in 2 ECG leads and or T-wave inversion, and they have to have ischemic chest pain on presentation. And the chest pain needs to be new and it's less than 12 hours. Okay? And there's a whole range of reasons. Exclusion criteria for these is a big one in there, left bundle branch block and STEMI. Okay, if the patient's got a left bundle branch block, flick open that page of the cardiac care circular and read that in detail. Take the time to stop and open it because it'll save you a whole lot of hassle and embarrassment as whatever skill grade you are. So you see the ST depression, great. Now after CAT session, I remember that's where the ST depression is, fab. What do I do with it? Open the cardiac care circular and that will tell you. It's your get out jail free card. It'll tell you what to do, okay? And hopefully what I've imparted will help as well. So T-waves, just to pardon me, just go through that. T-waves, ideally, it's a bit hard because in some leads, they need to be concordant. So they need to be pointing the same way as the QRS, as we said about the concordance and the disconcordance. However, again, this comes into our high-risk ACS, where it talks about flattened or abnormal T waves. They do happen, okay? So we want them rounded asymmetrical, which means they're a little bit pointy that way. We don't want them grossly abnormal, so we're going to show photos of that. What happens is in AVR, AVL, AVF, and a lot of these limb leads, they're a bit flat. And in, I think it's lead 3, yeah, in lead 3, T-wave inversions are normal, okay? So if you're bluing a patient to the cath lab with T-wave inversions and they've got chest pain and the only lead that it is in lead 3, please don't. So please put that in your memory somewhere that if you've got it in lead 3, it's completely normal and there's a pathology of why that happens. I'm not saying they're nothing though, because T-wave inversions do mean something and biphasic T-waves. But what I'm trying to say here is that they do occur a lot with different blocks, different morphologies. Inverted T-waves happen, don't stress. It's okay, they happen, but put it together with the whole picture. If you've got the T-wave abnormality, open up the cardiac care circular, have a look and see if it meets the criteria. So T-wave inversions are commonly found. So we're at that T-wave now. We've moved on from the ST segment. T-wave inversions are common, very, very, very common with blocks, with patients who are paced, with left ventricular hypertrophies and left bundle branch blocks with a huge range of things. So, and even raised ICP. So patients who have a raised ICP have something called arrowhead T-waves, but they are concerning. So inverted T-waves, we have a list over here from Life in the Fast Lane. Children commonly associated with T-waves, inverted T-waves, and you can have a persistent juvenile T-wave pattern when they get into their teens and things like that. Lots of other reasons that are concerning. This patient still needs to get investigation because they've got widespread T-wave inversion. With PEs, for example, they will be tachy and flip Ts, think PEs. So tachy, and so they're tachycardic, their heart rate's even just mildly 110. They've got flip Ts, think PEs, because 21% of patients with PEs will present tachy and flip Ts. There is this S1Q3T3 thing, but I think it has an incident rate of about 8%. So what we should be teaching people is about tachy, flip Ts, think PEs. I'm not saying it is. There's so many reasons it could be, but 21% of patients with PEs have that in their ECG. So what it's saying is, yes, you've got these T-wave inversions. Do they need to go to a cath lab? Not always, but open the guidelines. So we've got here a whole range of reasons that you can look through in your own time. So this is what I'm talking about. We've got this top one up here where it says V3, which I think is our hyperkalemias. Did I say that one was? Oh, hypokalemias, my apologies. Hypokalemias is this top one at V3. Then we've got, if we move across to the next black and white one, we've got some very concerning T waves there because they've got ST elevation. That's the picture that's V2 and V3 in the right corner. They're concerning, okay? These hyperkalemia ones in V3, they're concerning too, but they're not a cath lab really, are they? They're big, but they're big because of the hyperkalemia. We go down to the second black and white photo on the far right side where it says V2, V5, V6, and we see these big, huge T waves. And these are due to our ICP. So patients with increased ICP, and ICP is intracranial pressure. So patients had a head injury, they're bleeding into their skull, and because of the pressure that that's putting, let's try and get over here. Because of the pressure that that's putting, because of the pressure that that's putting on the brain, it does some funny things to the ECG. The next one that we have here, right down the bottom, the kind of longer strip that says 1, 2, AVR, AVL. We look at that and I actually think, because, you know, you can have some T-wave inversions in AVL. I said that's not that abnormal. But if we look over at V5 and V6, we can see there that we've got those T waves, the inverted T waves, and this is a concern. Okay, so this is the morphology that we're looking for, that we're concerned by. And this is straight from a patient having an MI. So I'm not going to say it always is because it needs to meet the criteria, but this is what you should be starting to be concerned about. The same again goes with our, I think I've cut that one off. Got some other ones there. We do have down the bottom where it says pattern A, pattern B, and these are all about our brigadas and things like that, where they're grossly abnormal. So it's the things that are standing out to you and you think that just doesn't look right. Not saying they're cath lab, but they definitely need some investigation. This big coloured ECG up here where you can see all the leads. Again, the same principles. We look at lead 2. It doesn't look too bad. There's a bit of depression there. And we look and there is widespread ST depression. But what we can, and T-wave abnormality, but what we can see is that bunny ears. So that right bundle branch block. So that tells us that it's fitting with, you know, what it is, and it may not be concerning. But the rest are a little bit concerning. So moving on, just some more ones of common pathologies. Down the bottom here is a left bundle branch block, and just quickly on that, it's basically big, wide QRSs. Big, wide, and they're running off the page or they're running into the next page. That's usually a left bundle branch block. And the T wave is just abnormal. This patient is fine, provided they've got no other acute concerning factors. This may be normal for them, okay? But it's just about learning and seeing lots and lots of them. Again, up the top there, we've got the right bundle branch block. And the other one that is in the middle, just to give you some view, is that is our strain pattern. So we get funny little strain patterns where it does funny things to the T wave, but it's normal for them. So it's all putting it together as part of a big puzzle. So moving on, just being cognizant of time, is there any questions before we move into, we're going to apply these to some ECGs, and this is where you get your Slido out again, and you guys will apply those 6 rules to these ECGs that we have. Did anyone have any questions at all before we move on? Anything that didn't make sense? All good? Yeah, cool, perfect. So let me just bring up our Slido for today. We're just going to go through this ECG. So obviously this is a generated one, but it's the easiest one to kind of view. So what we'd like to do is apply those 6 steps. So let me just get, so grab out your pen and paper if you don't mind. And that photo that I got you to take, bring that up, because it's all about having the tools at the moment to look at these things. This should only take another 10-ish, 10, 15 minutes. If anyone needs to go, no problem. But if you can stay. This is where we get to consolidate some of it. So let's go through, and I'll get you all to do it in your own time. You've got that picture that I gave you before. If anyone doesn't have it, let me know and I'll put it in the chat. You want to join later? Let me just bring it up here. So in that, it said about the rate, regularity. For this one, again, if you're counting the rate, you go from 1 QRS, count it along to the next one. It's okay if it's just a rough estimate. Use your calculator on your phone, so on and so forth, to work out the rate. I'll give you a few minutes to go through that one and just work out what we've got there, basically. And if you just want to click done into the group chat when you guys are done. Let's try and get this up. Done. Cool. ECG guest 1. I'm guessing that's Josh. Perfect. We'll give it a few more minutes for people to go through. Cool. Done. And we will go through this. If anyone's a bit overwhelmed and it's just not quite making sense, it's absolutely fine. We'll go through it together. And it just needs to be really short and simple. Cool. Okay, great. That's fine. You guys don't need to put, we've got enough to say that most people are done. We'll give it another few minutes. It just can be simple as well, like the P wave. It's upright, it's rounded, it's there. It doesn't have to be super complex. You need to talk about everything in it. Just put the main kind of things that you can see, but the more the better. Okay, so we'll go through this, and then the next one I'll give you a bit more time to do, and we'll use a Slido so you guys can put your answers in there. But this is just a nice, easy one to ease into. So going into this, I've got the green, basically how I did it, okay? So on the next one, you guys will be putting your answers, but hopefully it matches with what you've got there. So the rate regulation, and I should have put ratio in there, but I forgot to. The rate I worked out is regular, and it's a rate of 78.9 beats per minute. About 80, oh, it's 79, 80. What I did with that is I went 300 divided by 3.8 because it's almost, if we look at 1, 2, 3, the third to fourth complex, we can see that it's not quite 4 boxes, but it's just a little bit before. So I went 3.8 because it looks about 80% of a full square, and that gave me the rate there. It looks regular. There's a P wave before every QRS wave. Happy days. Down to the P wave preceding the QRS, it's upright, it's rounded. How I did that is I just looked at the P waves on the strip. PR interval is between 0.12 and 0.20. Okay, so I looked at this one and we can see that, yep, it's in between one of those big boxes, which is great. Where are we? The QRS complex. This one's probably the most simple, unless it's grossly abnormal. It's neat, it's narrow, no lumps, no bumps. It's less than 0.12. You could almost argue it ventures a little bit further than that. It's a little bit wide, but yeah, it just gets in between those 2 small boxes. Okay. ST segment. This is the ever so slightly more important one. I compared it. It looks ever so slightly, maybe it's under, but it looks almost identical. So I said it's isoelectric. There's no elevation. I compared the PR to the ST. And then the T wave, they're concordant, they're non-biphasic, so they go just one way, and they're asymmetrical, so it kind of arches up. Did anyone have anything different on that? Or did you have some variation of that? It doesn't have to be word perfect. About the same, nodding heads for the heads that I can see? Yep, perfect. That's all, and that's hopefully what you can take away from today is this 6-step method as a new learner. So the next one, everyone got their pen out again and that 6-step method applied, and we'll go into one and then we'll be popping it into Slido as well after you've got your thoughts on it. And the main thing with this one is there'll be an underneath, the question will be what's abnormal basically about it. So I'll give you a few minutes there, and I will, if you go back into the Slido, it should say ECG and what is the main concern abnormality. And to get to that, you need to do the P, the rate, the PR interval, QRS, T wave, all that kind of stuff. And then the main thing that stands out as abnormal. Very simple. Not here to trick you. I'll give you a moment with that. Cool. And if you go into the same Slido code, which I'll chuck in here if no one has it, 138925. If you go on back onto Slido on any other device, and it'll come up with ECG1 question, and you can free type in there what your main concern. So from this 6 steps, what is the main thing that jumps out that you go, oh my gosh, that's weird? That's basically all I want you to write in there, and it's all anonymous. So don't be afraid to write something in there that you think might be wrong. Great, so we're getting some really good answers. Can you guys see the Slido, the picture it's giving you, or no? Josh, is that a yes? Like you can see the word art that's coming up? Okay, perfect, good. Wasn't sure if that would pop up or not. Perfect, so keep putting them in there. We've got 5 responses. Fast and regularity, yep. Sinus tachy, rate. We'll wait till we get at least half people who have gone through that one. And any questions, if anyone's got any questions, you can ask now. No, hopefully it's all just making sense rather than you're quiet because it's unknown. Perfect. All right, so we've got 10 responses, which is good. Perfect. So coming back to that, I think everyone's got the same kind of response with this one, is that it is fast. Anyone get anything different that they want to talk about? No? Cool, perfect. So for this one, obviously the machine, again, would tell you up the top what it is, but I'm trying to get you in the pattern of doing it step by step. And that way you won't miss anything. And even if you don't calculate it with this calculation, you'll at least, sorry, I forgot to open that one up. You'll at least know how to do it if the machine doesn't do it for you, because sometimes it just doesn't have anything up the top. So perfect. So really simply for this one, the rate was the big thing with this one. So it's very, very tachycardic. So how I got the rate is if we look between the big boxes, there's about 1.5, something like that. So 300 divided by 1.5 gives us that rate of 200 beats per minute, give or take. Ratio of 1 to 1, which is our P to our QRS. And where were we? Yeah, so that's all we need to say about the ratio. But all of a sudden, straight away, that's your main issue. Still continue the 6 steps because you might find some ST elevation or depression, but you're pretty certain that that's the main concern at the moment. The PR to the PR interval, I said it precedes every QRS. It's upright, it's rounded. With these ones, you may get ST depression with tachycardias, and that's normal. If you've got ST depression and they're tachycardic, don't worry, it's fine, it happens, okay? And it's completely normal. Tachycardia is rarely associated, as we said earlier, with high mortality. ST segment is isoelectric, however slightly delayed. It's concordant. And the only thing in this one, as we've said, is it's really fast. Over 140 beats per minute is SVT, okay? Some literature will say 150, 140, 150, about 140, we start technically considering it SVT. For those who don't know, SVT is supraventricular tachycardia. So supra just meaning above ventricles, and it's fast. So it's originating above the ventricles and it's fast. That's all SVT breaks down into, okay? If it doesn't originate from above the ventricles, so it's a ventricular originated, it is not SVT, but that is ventricular tachycardia, and that's a whole different ballgame altogether. But yeah, that's what we've got with that one, and there's a whole way to treat that. So wait on this one just a second. That one I'll leave because I'm just cognizant of time. That one, if you want to do in your own time, and then in the PowerPoint slides that I've sent you guys, you've got all the answers there, but you can just focus on lead 2 if you're a new learner, or you can apply the 6 principles to all the leads. But being cognizant of time, I've got that. And again, another ECG to do in your own time. I know it's a bit hard to see, but if you just focus on maybe V2, you'll hopefully be able to see the thing that's standing out for you. And we've got that one there. So this is a great ECG that was sent to me last night by the lovely Jade. And the reason I love this is I've anonymized it, obviously, and whatnot. But sometimes you're going to go, great, these 6 rules are great, Kat, but what about these ECGs where everything's going on? Oh my gosh, I look at this, and lovely Jade as well told me her face dropped a little bit when this patient who called 111 had some mild chest pain, and his wife encouraged him, I think, to, correct me if I'm wrong as well, Jade, step in at any time, encouraged him to call 111 basically. 111 did a good job, and they generated 999 ambulance. And as you can see from there, you've got lots going on. Just look at the thing that's slapping you in the face. And obviously for this is the lead 2, lead 3, and AVF, that inferior leads. Don't worry at the moment for V2 and V3 being depressed. You can deal with that later. That's another step where we do some posterior ECGs to look at things further. You might have T waves, it might be slow, and Jay did mention that the patient became bradycardic at times because of other things, but just look at that inferior. And if we look at the STJ level, it tells us there is 5.7 mil of elevation, 5.9 mil of elevation. In this lead 3, there's 10 mil. That's huge. Well done. I think it was a positive outcome, she said as well.
Yeah, we did take
yeah.
at the end.
So well done for you. Good reason to get off late, I guess. Is there anything else to add to that, Jade?
No, that was pretty much it. He did walk out to the ambulance. He wanted to himself. He looked fine. No diaphoresis, no clamminess, nothing. He presented very well for a guy having that kind of MS.
Yeah. So, and that's what can happen. These patients can really trick you up. So we've all kind of been there and fallen into our own issues. But look at him as a newbie AAP. We call this the very uncolloquial term of tombstoning. So basically in lead 3, in that top ECG, it looks like a tombstone, and colloquially because they're heading that way, basically, if there's no intervention. But that's just showing on those big ECGs what we're kind of looking for. Don't get distracted by everything. And it says everything up the top. But the main thing you need to look at the top of there is meets STEMI ST elevation criteria. If it's not slapping you in the face already, that should be a little bit of an indication for you. So that's kind of our ECG there to look at, which is what we went through. Now a very quick ABC quiz to see if you're all listening, hopefully, and hopefully make sure I've hit the mark in the right way. So go back onto Slido. I'll open it back up for you all. And the quiz. So hopefully you can see the quiz pop up. It pop up with question 1. All we want to know is the P wave represents. And Josh or Jake, can you just let me know if it lets you do question 2, if it lets you do all of them. And this one isn't anonymized, I'm so sorry to say. So if you don't want to join in, oh no, it just says join participants. Maybe it does anonymize them. I shall see. It should be anonymized because it shouldn't know who you are. Yeah. No, for some reason it knows who you are. So apologies. If you don't want to participate, it's absolutely fine. If you can't get it to work and you want to pop things in there, yeah, I can see yours there, Dermot. You've added B. So perfect. So quick question 1 we've got there. Does it let you go on to the other questions, Josh and Jade? No?
Yeah, no, it just says get ready, and then I've got nothing.
Oh, okay, let me go start quiz.
Oh, no,
what about that now?
Here we go, got it.
Perfect, okay. Sorry, apologies. So
Oh,
question 1, okay, just as a percentage, it doesn't give your names on that one. Oh, it's changing. So people will see other people's remarks and change it. The P wave represents. So the P wave, you can flick back to the other notes and see what the P wave is. The P wave, what does it represent? And whoever's selecting D is now going, no, I don't think it's that. I don't think it's that. We've got 9 people, we've got a few more. Everyone's cottoned on and seen. I should have hidden that, so we've got a real respective account, but that's fine. Perfect, so we'll move on for that, just being cognizant of time. And correct answer for that one is B, so atrial depolarization. Okay, so that P wave is the atrial depolarization. The repolarization of the atria does occur, but basically it's hidden under the QRS. Okay, so you're never going to see the atria repolarization because the QRS is so big, the ventricles are so big, it takes all the electricity away. Perfect. So next question, and try and answer as honestly as you can. Even if you get it wrong, it's fine. We'll explain it. It tells me that some people get some things right, some people get them wrong, and that's fine. So, oh, did that go away then? Oh no, it's still going. Perfect. So the QRS represents. Go on your Slido. If you need to type it, it's fine. You can type it. I can see it there, which is great. Saying A. Perfect. This one's 100% A. Any last minute people, pop them in there. There's 10 or 11. We go to those. 11. Perfect. So 100%, which is A, which is great. So that ventricular depolarization. So I've hammered that in, which is excellent. Perfect. So the T wave represents. The T wave represents. And it said C. I put in there relaxation. I don't know why I've done that, but I have. Why not? Perfect. So we've got 8 coming in, 10 coming in, 11 including Dermot, which is great. Perfect. Constant of time looks the same. So the T wave represents that repolarization. Perfect. The PR should fall between. So you can look back on your notes. It's okay to look back on these notes because these little quizzes will help realize what you don't know. I don't care what you do and don't know. It's more bringing it to your awareness. I'm not here to berate you and, you know, make a big song and dance about it. It's mainly just to make sure you know where you're not exactly aware. So open that one up. The PR interval. So this isn't the P wave, it's the PR interval. So the P to the R section. Don't said C. And we've got 11 people saying C. Perfect. And C is correct. And our last one there, electrical depolarization energy coming towards the vector or the camera creates A. Always positive inflection, always negative inflection. Biphasic, which means it's kind of center. Can be positive, can be negative. I think we've got 8 who have come in. Change mine to D there, Dermot. That's fine. Martin says D. Interesting. We've got some interesting ones here. Some Ds, some Cs, and some As. Perfect. So this question was at the other end to see where we were with that. I think we're about there. So it tricks you because in multiple choice, your brain says if something says always, it must be wrong, basically. That's how I do multiple choice. If it says always or never, it's probably a wrong answer. Or if I've got no idea, I pick C. So with these ones as well, if the electricity, because it is a bit convoluted, I can see where you could justify that it's not. But if the electricity is coming in a straight line towards that vector, it will always give a positive inflection. If there's something in the way of it, that's when you get a negative or a biphasic one. Okay. Those who went D, you're not wrong to say that because you're saying it can be positive or negative dependent. So you're not completely wrong. I get where you're going with that, but it's just to hammer in that point again that if it's coming there in a very simplistic way, if it's coming towards that camera, it will always be that positive inflection. Okay. And last one, last few, the SA node, because I think we're all doing good on these ones. The SA node sits high in the left atrium, is represented as a Q wave on the ECG, fires automatically at a rate of 30 to 60, and has automaticity. We had a few A's. The A's have just gone away now, a few B's. So 20% of saying B's, which is fine. Don't go with the masses might be wrong. So who wants to be a millionaire, paramedic style? Yeah, I'll see audience and see what they say. Survey says, oh, great. So we've got 11% for A, 11% for B. As you can see, these questions are getting a bit kind of harder to test where your knowledge base is. Dominic, you've said A. Perfect. We've got a couple of A's. Oh, we've got 20% now A's. People are just are led very much by what other people are saying. No one for C. Good. A, B. Cool. Anyone else? Last few seconds. Perfect. So, oh, 27% for A. Interesting. So with this one, the correct answer for this one is it has automaticity. So that's the main one that's right. Why this is, it doesn't fire automatically at a rate of 30 to 60. That's not its intrinsic rate. So that one's wrong. It's represented as a Q wave. As we know, that QRS is all about the ventricles. It sits high in the left atrium. It's high in the right atrium. That's where that one's not quite right. But it does sit high up there, but it's just over to that right atrium is that SA node, and that's the only SA node. There is other areas which depolarize, but none that are called that SA node. But it's fine, because if lots of people are doing that, sometimes 27% of you thought. So if lots of you are going through that, that tells me that it's something to go back to. So following on from here, we've kind of reached the end now. Sorry, it was a little bit over. No. Following on from here, what can you do? Grab and print off the cardiac care circular 021. So that's for the hack admissions, okay? So that's the one that I've got the picture here, and it's in this link here, okay? And I'm going to put that in the chat. I know we've all got iPads, and I know we can bring it up at any time, but generally, if that patient is really, really unwell, your iPad might be down, you may not have internet, you may be out of battery, it may just not load for some reason or another. This is one of the only other things that I carry with me basically everywhere, okay? And as a new learner, it's even more important. And as experienced learners or experienced people with ECGs, we fall into the idea that we know everything. Oh, I've seen this before. I know that it goes to the cath lab. You will be tricked up. So really open it up and look at it. The other one that you've got is, so print it off and keep it. So print it off in colour, print it whatever size makes sense to you, put it in somewhere in your green bag, just somewhere on the ambulance each time. The other one that you can look at is cardiac care circular 012, and this says the indications for an ECG if you really want to go through it. So that has all the cardiac care information there. From here as well, as part of your consolidation, review the concepts that didn't make sense. If something in this just didn't really make sense and you're like, oh, I didn't want to speak up at the time, go back and review that and go through YouTube and stuff like that, or send me an email. If something didn't make sense, send me an email and I'm happy to talk all days about ECGs with you. And going on from here, keep learning. So ECGs aren't something that we can cover in just one day and get everything through. It takes years to really get your head around. But hopefully today what we've kind of presented is that really good basic understanding and explaining what's in each section, so you have a platform to go forward from here as new people in the service, basically. So where the cardiac care circular is on that link there. But if you go onto the Pulse, look under clinical and cardiac. No worries. Thanks for all these people saying thanks. You're very welcome. So questions. I'm just going to stop the recording now. So if there's anyone who has any questions, let me just find this.